Okay, we are about 2 minutes past the hour, so we'll get going. And just a note as we start here, we are recording this session so that we can share it with folks afterwards. But first, let me introduce myself. My name is Dan Olson. I'm the executive director of the Vermont Public Health Association, and really excited to have an opportunity to present some really fantastic work that two interns from Dartmouth's Master in Public Health program have been working with the Vermont Public Health Association on over the past few months. Um, about a year ago now, I was on a panel discussion at a conference in Washington, D.C. And during the panel discussion, I was sitting next to a fantastic woman who was a commissioner, a co-chair of Maryland's Commission on Public Health. And I was intrigued by what they were doing in Maryland. And I realized that I was not familiar with the use of public health commissions. I had heard that there had been one in Indiana, and it just left me with a lot of questions around how have other states been using public health commissions to advance the work of public health and to really elevate the status and the resources of public health within their states. Thankfully, we have a great relationship with Dartmouth Geisel School of Medicine, Master of Public Health program. We were fortunate enough to work with two Master of Public Health students, Emily and Elham, who I will introduce, or I'll let introduce themselves in a moment. And they were able this past semester to really tackle this question of what is a public health commission? How have they been used in other states? And they get really deep into interviewing commission participants, understanding their processes, understanding the results, and queuing that up for us today so that in Vermont, we can have that as another tool in our toolkit of policy levers that we can decide if it's applicable in our state. So with that, I'd actually like to turn it over to Ellen Malik, who is one of the MPH students from Dartmouth who we've been working with. And I will turn it over to Elham now. So Elham, you have the floor.
Hi, everyone. Thank you so much for joining. My name is Elham. I'm a Master's of Public Health student at Geisel School of Medicine. And I've been working with the Vermont Public Health Association alongside my colleague Emily for the last couple of months, and we're both deeply interested in policy. And we're really excited to learn and now share all we've been working on for the past couple of months. Emily, would you like to go ahead and introduce yourself?
Yeah, hi, I'm Emily Levonas, also a Master of Public Health student at Geisel alongside Elham. And yeah, this project has been extremely interesting for both of us. We've gotten a good taste of policy and kind of how that works alongside, public health. And so we're really excited to share all the work that we've done.
Awesome. Thank you so much, Emily, and thank you, Dan, for introducing us. So today we're going to Emily and I will sort of be going back and forth on this and trying to share some insights from our analysis of public health commissions, specifically looking at two pioneering states that have used this approach to transform their public health systems. And then we'll explore what commissions are, when they work best, and what we can learn from their real world implementations. So, our project goal was to develop essentially a framework for implementing effective public health commissions based on real-world case studies. And so, our approach analyzed, as I mentioned earlier, two successful commission models in Indiana and Maryland to identify best practices and critical success factors. And the key questions we were looking to address were, when are commissions most effective? What are essential elements of success for commissions? And how can jurisdictions assess readiness and plan for implementation? And so we chose to focus on these two states because they are two of the only states that have currently been in the process of having a public health commission. They represent complementary approaches, and Indiana was the first state to establish a public health commission and has completed its full cycle, while Maryland is the most recent commission that's still actively working. So we used a little bit of a formal or informal comparative case study analysis on our research design. So for case selection, we chose Indiana as our pioneer state commission model, which represents a completed life cycle for a commission, and then Maryland as our contemporary commission approach that started in 2023 and is now still going, showing ongoing implementation. And both represent different approaches and implementation stages, which give us valuable comparative insights. For our data, we included commission reports, final recommendations for both, and then enabling legislation and executive orders, implementation outcomes, funding impacts, and also stakeholder interviews and publicly available recordings of these commission meetings. And so we were able to sort of compare these cases and identify best practice and lessons learned for commission development across these different contexts. So for today's presentation, we've tried to organize it and parse it out into 5 different parts. First, we'll talk a little bit about commissions generally, what they are and how they work. And then I'll hand it off to Emily and she'll sort of share what she learned from Indiana, followed by what I learned about Maryland, and then sort of looking forward, where does that leave Vermont? How can this be applied in the state of Vermont? And then we'll share some of our final deliverables for our internship. So starting off by understanding what public health commissions are and how they function, um, let's go next, yeah. A public health commission is essentially an independent government body that's composed of appointed members who conduct systemic assessment of state or local public health systems and develop these evidence-based recommendations for improvement. These bodies have key characteristics. So they're temporary advisory bodies. They typically last 1 to 3 years. And they operate with some independence from political pressures, which allow for more objective analysis. And they're composed of multiple stakeholders from different sectors while focusing on specific challenges using an evidence-based approach. And unlike traditional government agencies, commissions can question existing practices and propose innovative solutions that might be politically difficult for officials to suggest. The multiple stakeholder composition typically includes public health professionals, academic experts, healthcare representatives, community leaders, people from maybe like the business or the philanthropic sectors, as well as government officials. So something that Emily and I sort of were looking at early on was what drives a state to form a commission? So states typically form public health commissions under 4 main circumstances from what we found in our research. First, for post-crisis assessment. So following emergencies that expose system weaknesses, the COVID-19 pandemic, for example, illustrated what happens when public health systems are inadequately funded or prepared. So that's one of the conditions under which our commissions were formed. Second, when facing persistent poor performance. So low health rankings, chronic underfunding, or poor health outcomes. Trust for America's Health reports an annual shortfall of $4.5 billion in necessary funding for comprehensive public health services nationwide. So again, one of the very important reasons why a commission would be formed. Third, when there are system modernization needs, so if there's outdated infrastructure, workforce gaps, or fragmented service delivery models, that's another reason why a state might consider a commission as an option. And fourth, during political windows of opportunity. So if there's new leadership that's seeking, new initiatives, legislative interest in reform, or when federal funding becomes available, a commission might be an option to address that sort of reform momentum and new leadership. So commissions work through a 3-stage process. So formation begins when they're created by legislation or executive order that establishes mandate, structure, membership, timeline, and funding. So a lot of the work for commission actually happens before a commission ever even begins. And the appointing authority selects members, and the selection process often signals how or can impact how seriously recommendations will eventually be taken. The composition typically includes 10 to 20 members representing different stakeholders that I mentioned earlier, and the sort of makeup of the commission can be both a strength and a challenge based on our research. The process involves systematic data collection, stakeholder engagement leading to evidence-based analysis, comprehensive policy recommendations, and public reporting of findings. For example, Maryland's commission, which I studied, conducted 73 stakeholder interviews, 12 focus groups, and surveys of 23 local health departments. And this rigorous approach really distinguishes commission work from typical policy development, as it really forces or encourages really, really intentional stakeholder engagement on a systems level. So commissions work best under specific conditions, and it's important to understand when they're appropriate to be used and when they're maybe not the best, the state is not the best candidate for a commission. Good candidates candidates include post-crisis assessment situations. So after emergencies that expose system weaknesses, they're also good for addressing persistent health challenges like poor rankings, chronic underfunding, and health disparities. Again, a lot of the very similar things that we mentioned earlier, system modernization needs, if there's outdated infrastructure, that's another good fit. And they work well, especially during a policy window where there's new leadership, reform interest, and available funding. However, commissions could be poor candidates for immediate crises that require rapid response. They're too slow for active emergencies, and they're also not needed when strong existing systems with effective mechanisms are already in place. If there's a lack of political will and leadership, it's unlikely to implement recommendations. A commission probably won't be effective. And finally, resource constraints. When there's no funding or severe timeline pressures, it can make a commission impractical. So taking a look at commissions from a little bit of a balanced view of what they can and cannot do. So there are significant benefits of a public health commission. They provide these independent, comprehensive analysis that would be impossible within regular bureaucratic structures, and they develop evidence-based recommendations through rigorous research methodologies. They enhance stakeholder engagement by creating limitations are equally important to understand when looking at commissions. Most fundamentally, commissions have no implementation authority. They can only make recommendations, and success depends entirely on political will, which can restrict the scope of analysis. Consensus pressure may water down recommendations to avoid controversial but necessary changes, and ultimately their success depends on political will. Recommendations can be ignored or delayed, and despite efforts at really balanced and inclusive representation, there are still challenges that persist within that. There can be geographic bias towards urban areas or professional bias favoring experts over community voices. So this is a visual that Emily and I created based off of sort of stakeholder interviews and seeing what would be a helpful way to sort of visualize what Maryland and Indiana did. And basically this like larger, darker green circle sort of represents a lot of all the different things that a commission can do. The application of it can be broad, but Indiana and Maryland specifically focused on a scoping analysis and creating policy recommendations.
Ellen, can I interrupt with one quick question?
Yes.
I saw in the chat, I believe that there's a question in the chat there that I thought it might be, since we have some time, best to answer as it comes up. And that chat was from Beth Schrader. What would an example of the strong existing systems, I think going back to the previous slide, be as an indicator of when a commission might not be recommended?
So in our conversations with stakeholders, I think one of the things that came up, and Emily, feel free to add on, was that if at that particular time, there is a sort of consensus and feeling that the system is already having really great coordination. There's really great, like, unified and a concerted effort to not only identify the issues that the system is facing, but then also address them. And they feel that there's good coordination and not a great deal of resistance. That generally seems to be the definition of, I would say, like good sort of system infrastructure and a strong existing system. Emily, I would be interested in hearing what you would have to say to that.
Yeah, I think, a strong existing system, it's kind of two-part. On one hand, if we think about service provision or, preventing negative health outcomes, just all of those sorts of things, if generally health is good in a state, and there's no, glaring disparities or anything like that, that's one half. And then on the other half, if there is a system in place of analyzing potential issues that could come up, and there really is a strong mechanism for actually addressing, like continually reviewing and addressing any potential coordination, health provision, disparity issues, maybe within a state, that sort of thing would probably be a quote unquote strong existing system that might not necessarily need this broad scoping review at a state level. So.
Great. Thank you both.
Thank you so much, Anna. I think you can move to the next slide.
Okay.
Yeah, so to wrap up our background and sort of what we did and why we did it, just briefly to turn our attention to the socio-ecological model. I'm sure many of you are familiar with it. And essentially, Emily and I were really intentional to use this model to approach our work and analysis of the commission. It shows how factors at the individual level and all of the other levels all interact with each other to influence health outcomes, and really that public health commissions almost operate at this policy level, this very, very high level perspective. There's a lot of really great things happening on the individual, interpersonal, and community level, but sort of pointing out that policy is where the Public Health Commission as a tool really lives. And now with all of that background, we can sort of look at how these principles played out in practice, starting with Indiana's Pioneering Commission, which I'll hand.
Yeah, so Indiana was the first state to implement this sort of thing. And it was born really out of three specific issues that the governor at the time and the state health department kind of realized about the state. So the commission was the governor's public health commission. And, as you can tell by the name, it was formed by the governor himself through an executive order on August 18th of 2021. It appointed 15 members and lasted for about 12 months. And these members were tasked with analyzing the current Indiana public health system to identify both the strengths and the weaknesses. Also analyze the performance of the state and local health departments during the COVID pandemic, and identify ways to improve public health delivery, any potential funding challenges and ways to address them, in addition to other ways to promote health equity, ensure local health department sustainability, and improve their emergency preparedness. All of these findings were meant to be put in a report alongside a select number of potential legislative proposals to enact any recommendations that the commission found could be helpful. And it was meant to sunset no later than December of the next year in 2022. But the commission actually ended early and was able to submit its final report in August of the next year. So a little bit of additional background. The three main things that I just mentioned, which contributed to the formation of the commission, were poor state public health rankings, underfunding of local health departments, and then strain that was made very visible by the COVID-19 pandemic. So in 2019, Indiana's life expectancy was 77 years versus the US average of 78.8. So it was 40th in the nation for this ranking, for this metric. And then also in 2019, the state was 41st overall for health outcomes. And in 2021, it was 40th overall for public health. So these persistent low public health rankings and health rankings in general were a concern for the state, especially since the governor and a lot of stakeholders were really trying to improve business and economy in the state, and having rankings like this were kind of negative in terms of drawing people in to live there. And then the local health departments were also pretty underfunded. So Indiana is a home rule state, meaning that counties and local health departments are the main point of contact for public health service delivery, and they are funded by taxes in that area. So in 2018, the state was 48th for public health funding. The national median spend for local health departments per capita was $41. And all but two of Indiana's local health departments spent below this. And then 37 of 92 counties, which contain local health departments, actually spent less than $10 per capita. So the public health funding was a major issue that was identified. And then, during COVID-19, the strain that was put on the public health system in terms of workforce, supplies, coordination, all of that stuff really put public health infrastructure to the forefront of a lot of people's minds. So in August of 2021, the governor signed Executive Order 2121, doing all the things that I just mentioned before. 15 members were appointed to this commission, and they had 10 meetings monthly and sunsetted on August 1st of 2022 with the publication of their final report. And this report contained 32 policy recommendations across 6 different work streams, which were things like workforce, emergency preparedness, etc. And then the impact of the Governor's Public Health Commission, it actually resulted in 2 pieces of legislation being passed. So the first was Senate Bill 4, or Senate Enrolled Act 4, which defined 23 core public health services meant to be provided at the local health level. And it also created this new system called Health First Indiana, which was an opt-in funding system for these local health departments. And then House Bill 1001 also passed that year, provided the funding for this new program, which was Health First Indiana. And so the House Bill 1001 gave 75 million in fiscal year 2024, and then increased it to 150 million in fiscal year 2025 to be provided as local level funding for public health, local health departments. And this was an opt-in state funding. Local health departments and counties could decide whether or not they wanted to gain this additional state funding. And opting in also came with an agreement to provide those 23 local core public health services, as well as create metrics for measuring and collecting data on the performance of the local health department to be reported on a yearly basis. And then that's all about Indiana. So I'm going to hand it back to Elham to talk about her experience with Maryland.
Thank you so much. So yeah, we can dive a little bit deeper into what I think makes Maryland's approach really compelling. And so the commission emerged from what I would consider to be, or call, like a perfect storm of conditions. So post-COVID lessons that sort of turned into momentum combined with some, I would say, pretty sobering health data that they ultimately decided demanded action. And I think the background here is really important because Maryland, despite being one of the nation's wealthiest countries, um, had concerning health rankings that provided evidence for action. And so they ranked at that time 25th nationally in life expectancy, 29th in infant mortality, and 45th in drug overdose deaths. And so one of the delegates who was co-sponsoring the bill actually articulated it really well, sort of saying that, the COVID-19 pandemic has highlighted major gaps in the state's response to public health emergencies, and resources were really not distributed equally amongst zip codes and at-risk populations, which as a result, when forming the commission, sort of centered health equity as one of their primary concerns for their commission. And the legislative journey itself and that process was really instructive. The delegate Ariana Kelly, who introduced House Bill 214 in January 2023, and the momentum was pretty instantaneous. By February, they had 15 witnesses testifying in support, who provided crucial legitimacy by citing precedent states in states like Indiana, and then some other states that were sort of playing with the idea of a commission. And the Maryland Association of Counties also played a really big role. They were able to secure that geographic representation amendments to ensure that rural, suburban, and urban communities all had a voice and had a seat at the table. And by March, it was able to pass with unanimous committee support, and Governor Moore signed it May 3rd, which was remarkably fast for legislation, especially of this scope. And so going to the next slide, what really I think sort of singles Maryland out and really helps them stand out is their tri-chair leadership model. So unlike instead of a single chair who might represent one perspective, they actually had 3 co-chairs representing complementary domains. And with health equity sort of at the forefront, one of the co-chairs actually, being professor who brought community engagement equity focus, specifically HBCU representation, which was a really important part of that decision making of forming that commission. And the structure avoids what we often see in commissions and task forces of any kind, where you have that sort of single perspective dominance. And so each co-chair brought different expertise and networks, which was able to expand the commission's reach and credibility. Another thing that really makes Maryland stand out was their academic partnership. And so they worked closely with the University of Maryland's School of Public Health. They had over 20 faculty and staff involved across work groups. They had graduate student interns who were providing research support. And so it was more than just having an academic voice on the commission, but actually this like embedded academic capacity for analysis, which was really beneficial. They organized their commission into 5 specialized work groups. So they decided they wanted to focus on governance and organizational capabilities, funding, workforce, data and information technology, and communications, along with public engagement. And each work group was led by a commission member, but also supported by subject matter experts from across the state. The stakeholder engagement, I think, to me, really stood out in my research because they've involved over 130 participants total. And that's not just the 16 commission members, but people working across all the different work groups. And they conducted 5 regional listening sessions covering all geographic areas of the state, really making sure, going back to some of the original commentary that led to the legislation, that they weren't ignoring certain zip codes in sort of in their reach. And so other things that they sort of did to really put health equity at the forefront of the commission was providing ASL, Spanish interpreters, with materials available in both English and Spanish. They also recorded all of their sessions and put them online, which really establishes unprecedented transparency standards, and sort of rotating meeting locations across counties to reduce geographic barriers. Despite the comprehensive approach, Maryland also did face significant resource constraints. When the bill was passed in 2023, there was actually no designated funding for the initiative. So really also highlighting that as something to consider when states are putting together a commission. And with 130 people working across the commission and work groups, they needed these substantial resources. And so their solution eventually was to build partnerships with the CDC Foundation, some academic institutional support, and some other key stakeholders that were able to sort of support their need for financial and staffing support, volunteer expert engagement, and shared resource utilization. In January 2025, they released their comprehensive 2024 interim report, and their findings. They were able to identify workforce shortages as the most persistent challenge, with examples of St. Mary's County scaling from 100 to 330 employees during COVID-19 without experienced leadership for that rapid expansion. They were able to also document substantial funding disparities, with Maryland's funding formula largely being unchanged since 1897 and the last update being in 1997, creating these significant inequities across all of the 24 jurisdictions. And so looking forward, Maryland's commission is working on drafting final recommendations informed by the assessment findings, with draft recommendations schedules for public review end of July 2025 and final recommendations due to the Governor and General Assembly by October 1st, 2025. And what Maryland demonstrates is that systematic public health system assessment is achievable with appropriate leadership and stakeholder engagement, as well as resource mobilization. And their tri-chair model, as well as their academic integration, comprehensive stakeholder engagement, offers these transferable innovations. And their research challenges ultimately show the significant coordination required for success. And most importantly, Maryland shows that even without final recommendations, commission work can establish what they refer to as a sense of direction and confidence for systematic public health improvement, creating value that sort of extends beyond specific policy outcomes to enhance stakeholder relationships and system understanding.
Yeah, so after hearing all of that, the real purpose of doing this research was to think about what does all of this mean for Vermont? And the thing that Elham and I really have settled on is that a commission and a public health commission in general is a tool that a state can use in order to address something specific to their circumstance. So it's not a one-size-fits-all model. Indiana and Maryland were very different. They did very different things. And whereas maybe there were some similarities, in terms of COVID, problems that arose during that kind of led to the formation of the commission. The baseline that each state was operating from at the start was very different. And Vermont does pretty well in general with health rankings, but there are some things that, could always be improved. And so thinking about a little bit of an overview of Vermont, the State Health Improvement Plan of 2019 to 2023 identifies 6 different health priorities, including child development, chronic disease, mental health, oral health, substance use, and social determinants like housing and transportation. So all of these things are kind of on the forefront of people's minds in terms of improving the health system. And then we also had Act 167 in 2022 passed by the Vermont legislature, which called for payment and delivery reforms, including a draft proposal for a multi-payer alternative model, and then expanding and integrating healthcare databases. So this act, shows that there might be some sort of initiative for modernization and kind of changing up the way that things are going. However, it did not mention public health specifically, but as we know, public health does contribute to downstream health outcomes. It's not just about hospital systems. And then that report also contributed to the publication of the Oliver Wyman report, which highlighted affordability, sustainability, and access concerns. So there are these conversations going on a more structural level about how, potential things that could be addressed. And then there are other prominent topics that kind of came up in our discussions with various people involved in, the Vermont healthcare system scene, which were flooding, so natural disaster preparedness, climate change being an upstream, driver of that, rurality, Vermont being a small state overall, but also having people kind of very spread out. Data modernization might be an issue, and then housing and transportation, like what I just said regarding the social determinants in the State Health Improvement Plan. So a commission can address all of these things, some of these things, or none of these things. It really can be utilized as stakeholders see fit. But the most important thing would be to have or to assess and then also generate that buy-in to really do something and make it meaningful. And so knowing that, it's very necessary to assess whether or not there is an appetite for this sort of work. A public health commission is a very flexible mechanism for doing a general state of the state analysis, as one of the Indiana representatives put it, and is a really great tool for initiating statewide policy change if it is done right. And so we can go on to the next slide. So our conclusions on our next slides our key findings from this work were that commissions work best post-crisis or during reform windows. So if there is something that is happening in the state or that has happened to the state that a lot of people are aware of, and sorry, thank you, Megan. If there's something that has happened in the state that a lot of people are aware of, that might be both a post-crisis opportunity and a reform window where, it's on the forefront of a lot of people's minds. And also we found that the success really does require political will and dedicated funding. In the case of Indiana, having the governor's constant support was huge for actually getting people to buy in and take the recommendations seriously. And then Indiana also was supported by philanthropic funding, so that gave a lot of legitimacy to the effort. And then as we saw with Maryland, getting the legislature to pass a bill quite quickly was also really got it going. So Vermont has both opportunities and existing strengths, kind of as I just mentioned with the overview before. And then we have some recommendations as well. So we might want to consider a commission focused on climate or rural health, which, given the floodings that happened in the past couple of years, there might be an opportunity there for improving coordination and cohesion in the response effort. We can leverage the momentum that's been generated by Act 167, just latching onto that mention of a need for some sort of scoping review. And then we'd also need to ensure an adequate timeline and resources, which is always one of the biggest barriers to kind of implementing any new thing. And then the next steps might be to broaden stakeholder consultation, really getting the word out there, which is part of what this webinar actually was intending to do, was to really just create the conversation and get the thoughts going. And then you'd also want to assess whether or not there is kind of that window in the legislature. So is it feasible to begin these conversations at a more serious level? And then also to develop a timeline. It's really important to strategize how these things will play out before you actually start to do them in order to kind of avert any sort of confusion. So I can hand it off to Elham. She might go into the deliverables for our internship a little bit.
Yeah, so thank you, Emily, for your part. And I think ultimately when it came down to it, having this context is really, really helpful. And we wanted to make sure that, before we transition off to our next step, that we hand off something that would be really helpful just for anyone interested in commissions. So Emily worked on the Indiana Government Public Health Commission. I worked on the Maryland Commission on Public Health. And we both developed pretty comprehensive reports on our findings, just based on, obviously existing information that's public information, and then also sort of our conversations with various stakeholders. So that was our first deliverable that the Vermont Public Health Association and anyone else that would be interested in it will have access to. And then going to the next slide, we also worked on a toolkit. So based on our conversations with stakeholders, what we really found and we thought would be most helpful was a really high-level overview of what commissions are and essentially a fact sheet for all those different pieces. So for example, if you look on the screen, the Public Health Commission overview, that's just a very general high level sort of summary of what commissions are. A lot of it is stuff that you've seen during the presentation today, then going into state commission examples, so Indiana and Maryland having their own fact sheet. And then the last piece, which is the implementation planning guide, which I'll allow Emily to go more into. And for that, I think we can go to the next slide.
Yeah, so I think this slide is a little off kilter, but this was something that I developed kind of jointly with Elham based off of our interviews and conversations that we had with commissioners who were actively engaged in either the Indiana Commission or the Maryland one. And so this is coming from people who were participants in this sort of work. And so we've kind of summarized a lot of the things that they had to say about what they thought went well in their state's process or any potential oversights or things that they could have done better, and have tried to put them into this deliverable, dividing it into 3 stages of planning, process, and post-commission. So planning being all the stuff that leads up to the initial implementation legislation or executive order, and then the process being any sort of structural elements that during the actual timeline of the commission might help or hinder the ultimate deliverable. And then post-commission, how do you get your recommendations effectively implemented and make sure that, they don't just get shelved, or communication strategies for, talking to legislators or just ensuring buy-in to the actual deliverable at the end. And then our key takeaway really from this presentation and project in general was, even if any sort of recommendations that a commission publishes wouldn't be feasible for another few years, it could be helpful to think about those strategies now so that when the time comes, people aren't just working from ground zero. So a commission can really establish a sense of direction and confidence by reviewing what is going on at the state level, identifying any gaps, identifying any strengths as well, and then just creating something to kind of have on the side for when the time comes and there is any sort of initiative so that changes can be made quickly. And we just want to thank you guys so much for coming and listening to us. Yeah.
Well, thank you so much, Elham and Emily. We have some time, and we'd love to entertain any questions from those of you who have been with us for the presentation, if there are any. So feel free to unmute yourself and shout out a question if you have one. I'll stop sharing so that people can see faces if anyone wants to talk.
I have a question about, Vermont doesn't have a lot of public health departments. So you mentioned, I think it was in Maryland, there was 23 public health departments in the state. We don't have that structure. So that, I mean, some towns, I suppose, some larger towns, I live in the middle of nowhere, we don't have anything like that. But I wonder, in a place like Vermont where there aren't any public health departments within towns, would you see this being a better fit to have a commission when there's not those local health departments?
Yeah, I'm happy to answer that again, Emily. Feel free to hop on. I think Indiana also has a lot of lessons for Vermont. And thank you for your question. I think yes, obviously there are less chapters, and I think that a commission from our joint research can really be anything you want it to be. And I think that while, obviously we don't have as many chapters to analyze as Maryland did, I think the component of regional listening sessions would be specifically really, really, I think, interesting for Vermont to explore. What they were able to accomplish with the regional listening sessions is that they would have these sessions in places that are, really easily accessible to the community, and they had incentives for the community to sort of join, and they're a whole very like thorough structure of how they did it, and I think that sort of comprehensive sort of conversation and that attention that was given to each zip code, I think would be really important. I could see there being benefit for the state of Vermont, especially considering like the rural nature of the state of Vermont and how important it would be that as big as Vermont is, that we're able to sort of get all of those voices at the table in a way that's accessible and convenient for them.
Yeah, thank you for your question as well. Elham, you did a really great job of answering that. I think to add in just a little bit, so the commissions that Maryland and Indiana both did, none of it was really on the implementation side. So they weren't like delivering any sort of services or anything. It was really this temporary analysis and recommendation to create policy initiatives that maybe changed the way that implementation was running, but it wasn't like the creation of a new body to go in at the local level or whatever. But I agree. I mean, Vermont is very different from Indiana in particular. Indiana is on the polar opposite spectrum in terms of how it's set up. They're completely home rule. So there's a ton of local variation as opposed to Vermont's more centralized public health system. And from some of the, conversations we were having, it seems that there are fewer of those, local department branches of, the State Department, but they make their own partnerships with various different groups or organizations that exist in the local area that may not be the same, across different areas of the state. And so a commission would just kind of be a way to analyze the very specific strengths and weaknesses that already are present in the state, and then identify how do you make the strengths stronger, how do you fill in the gaps, that sort of thing. And going back to what Elham said, something that both Indiana and Maryland did was to really get out there and offer a chance for the public to give their input about the way that the public health system was functioning in general. Indiana also did state listening tours, and they live streamed and had all of their meetings open to the public, and there were feedback forms. And so I think that is a crucial aspect of any sort of public health commission, is really getting the people themselves to have the ability to talk about their experience with the system and offer up any sort of concerns or things like that. So thank you so much for your question.
Any other questions from the audience? And Janley, are you addressing us? Sorry, so you're on mute.
Yes, I'm on mute.
Ah.
Sorry about that.
That's okay.
I had the benefit of being able to see part of these presentations last week, and I also am so impressed, Emily and Ellen, by your ability to present this in different formats. And last week they were given 5 minutes each, so it was really neat to see the expanded version of this. But my question, and this is completely biased because I work in career services at Geisel, so I work with employment and sort of think about outcomes a lot. And one of the things I like to think about a lot is how your experience impacts your long-term goals. And so my question to you is, how did this in any way impact your own professional career goals? And if so, how?
I mean, it was really interesting to be able to speak with people who were engaged with this sort of work from two different angles. I mean, one, seeing that these commissions brought so many people from different backgrounds and different professional circles into the same general table. So it was cool to just get a sense of all the varieties of different professions that exist in public health. For myself in particular, I'm, interested in law and policy, and so this kind of fit right in with just another strategy for thinking about how to improve structural things through policy. So
Yeah, I would echo a lot of that. And I think also being interested in health policy, seeing a lot of going through this and sort of seeing like this is a lot of the prerequisite work of to get anything done on a systems level, and to be able to have those conversations with people and do really in-depth research and see like how can we, frame this in a way that makes sense and that's easy to digest and also applicable to their context, making sure that we're not duplicating work that's already being done, and that we're being really intentional about that. I think that was obviously you learn about those things, but I think in practice it feels different and it pans out differently. And then to be able to I think for Emily and I, like in the beginning, not knowing anything about public health commissions, and then now knowing maybe a little bit too much about public health commissions, like how can we sort of work backwards and kind of reframe all the material that we've now learned with sort of like someone who has never worked with public health commission in mind. Like how can we synthesize that information in a way that's really helpful, and in a way that maybe we wish that we had access to it when we started. That was definitely really interesting.
Thank you.
Well, I just want to say a tremendous thanks from the Vermont Public Health Association. It's been a great process for me working both with Emily and Elham. I think that I started from a similar, maybe a one step up, but just a short step up from your starting point. And I feel like we were really able to learn a lot. And I think what I also really appreciate is this project wasn't approached from the perspective of, oh, Vermont should do a commission, but really like, what is a commission as a tool, and how could we help create an understanding of what this tool is, so that Vermonters would be able to understand better if or when a commission would be additive and not duplicative. As both Emily and Elham have said, like Vermont has some strengths. We have a fantastic, our health assessment that the Vermont Department of Health does every year. There's a lot of work going on right now. And I think that I also have a question. I think the Vermont Public Health Association has a question too of, when we have things like the Oliver Wyman report coming out, really focusing on healthcare and cost and healthcare delivery, is public health also being viewed and evaluated, and strategies created on a similar forward-looking basis of, we do some things great in the state, and we also have some really unique challenges given the rurality of the state, small population, funding, et cetera. So I just really appreciate the open spirit of inquiry that both Elham and Emily brought. Really, hopefully some fantastic conversations to talk with commissioners and learn from others. And I think we've got a great final product here. We will be putting both this video as well as all the final deliverables that were created up on our website. I'll send those out on a blog post with a recording of this video so you can share it with others if you think that they would benefit from seeing this work. And again, just wanted to say thank you so much to Elham and Emily and to Dartmouth for partnering with us on this project. Okay, well, unless there's any other questions, we will wrap it up there. Again, thank you to our presenters as well as to the participants today. Have a fantastic afternoon. Thank you.